Have you engaged in any conduct that is unprofessional as a physician in the last 10 years?
Well, what do you mean by unprofessional?
What does unprofessional mean to you, doctor?
Well, in my mind, unprofessional is doing practice as a doctor outside of what is expected of me.
Okay. Have you engaged in any conduct that is unprofessional as a physician in the last 10 years?
Same
No.
objection.
Have you engaged in any conduct that is dishonorable as a physician in the last 10 years?
Same
Can
objection.
you define dishonorable?
How would you define dishonorable?
I would define dishonorable as something that is out of moral character.
Okay. Have you engaged in any of that conduct in the last 10 years?
No.
Have you engaged in any conduct that is unethical as a physician in the last 10 years?
No.
Doctor, are you familiar with the recognized standard of acceptable professional practice for a physician practicing in Nashville, Tennessee?
Yes.
And what does that standard mean to you?
The standard is I would be doing the same standard of medical practice as any medical practitioner in the same location or similar location as I was.
Doctor, do you agree that patient safety is a top priority?
Yes.
And do you agree that one of the first concepts for a physician is to do no harm to your patient?
Yes.
Do you agree that patient safety and the standard of care go hand in hand?
Yes.
Do you agree that when there's more than one way to treat the patient, you should select the safest way possible?
Yes.
What was, back in June of 2010, the safety plan at your Nashville office for handling patients with Priapism?
The safety plan is to take the safest approach that is most effective.
And what was that safest approach?
The safest approach is to use the oral route to help the patient for that problem that I diagnosed.
Any other part of the safety plan other than taking the oral route?
Rephrase this question again.
Any other part of the safety plan other than taking the oral route?
Any approach? Not that I can think right now.
Okay. What was the oral route?
The oral route is the use of the PDE inhibitors, and for example, Viagra.
Anything else?
Then if it doesn't work, then we try something else.
What would that something else be?
That would be using the Trimix for the problem that I diagnosed.
Okay. I'm not sure we're communicating, maybe it's my fault.
Yeah.
My question is, back in June of 2010, when a patient came to your office that you were treating who had a priapism, I want to know what your safety plan was.
It was not in June when he came for Priapism.
I'm not asking when he came. I'm asking you, sir, in June of 2010, what was your safety plan for treating a patient with a priapism?
My safety plan would be to explain to the patient that that's a possibility, and to give the Sudafed medication as one of the antidotes, and to call me if it happens. And then I can see the patient, and depending on what my findings are, then I can refer the patient to a urologist.
That was the safety plan.
That's the safety plan.
Back in June of 2010, was there a urologist who you consulted with?
No, not that I can remember at that time.
You can't remember, or you did not?
I can't remember.
Have you consulted with a urologist since 2010 about the use of trimix or complications related to trimix?
No, I just look for more information on the internet.
Doctor, how many patients in your practice, you estimate for me, have you prescribed trimix to?
I would say 5 or less, in my recollection.
Throughout your entire career?
Yes, it's not my regular type of practice.
Do you have any expertise in trimix?
I'm qualified, but I'm not an expert.
Okay. Can you describe what you mean by being qualified?
That I'm able to prescribe trimix with the knowledge that's available for a general practitioner. We deal with different cases, and erectile dysfunction is just one of those.
Well, what I want to know is, did you do any particular study, any particular training with regard to the use of trimix before you started treating Mr. Culp?
I already told you I was getting information from the internet.
Okay. Other than going on the internet, is there any other means of research, training, or experience that you had in prescribing trimix before Mr. Culp was your patient?
I have with the other patients. I had experience.
So treating, how many times did you prescribe trimix to patients before Mr. Culp was your patient?
I don't recall exactly, but for every patient that I have prescribed, I think there were 2 that got the prescription more than one, if that's what you're driving at.
Yes, sir. Do you remember the first year you prescribed trimix to a patient?
It must have been in 2010.
Okay. Same year Mr. Culp was your patient?
Yes.
Right. Besides prescribing trimix to those 2 patients before Mr. Culp and going on the internet to do some research, any other work you did in terms of experience, training, or research with regard to trimix?
No.
Okay. Doctor, have you read the American Urological Association's guidelines on the management of Priapism?
No.
Do you agree Priapism is a medical emergency?
Yes.
Do you agree that all patients with Priapism should be evaluated emergently in order to intervene as soon as possible?
Yes.
Do you agree the goal of the management of all patients with Priapism is to achieve detumescence and preserve erectile function?
Yes.
What is detumescence?
Detumescence is to restore the flaccid status of the penile organ.
So it's not hard anymore.
It's not hard anymore.
Do you agree that Priapism is defined as a persistent penile erection that continues hours beyond or is unrelated to sexual stimulation?
Yes.
Do you agree Priapism requires prompt evaluation and may require emergency management?
Yes.
Do you agree that an ischemic Priapism is a non-sexual persistent erection characterized by little or no cavernous blood flow and abnormal cavernous blood gases.
Yes, these are all general supposition about Priapism.
That patients with ischemic priapism typically report significant pain in their penis.
Yes,
That ischemic priapism is an emergency.
yes,
That resolution of ischemic priapism is characterized by the penis returning to a flaccid, non-painful state.
yes,
Is the color duplex ultrasonography a means to determine whether a priapism has been resolved?
yes,
To verify it.
to verify it.
Doctor, do you agree the evaluation of the patient with priapism has three components? First is patient history, second is physical examination, third is laboratory and radiological assessment.
In general, yes.
Do you agree that in order to initiate appropriate management, the physician must determine whether the priapism is ischemic or non-ischemic?
Yes.
And what is a non-ischemic priapism?
Do I have to answer that? It's digging into this, the diagnostic part, and it's a judgmental call. We may not have to go through that. And if I was to deal with it, I would let the urologist make that decision.
Do you know what a non-ischemic priapism is and how it differs from an ischemic priapism?
Well, non-ischemic, there is no compromise of the viability of the tissue. Whereas the ischemic, there's already a compromise.
Isn't the difference, sir, that an ischemic priapism, that's the one that's an emergency. It's painful and it can lead to impotence, can't it?
It can, yes.
Doctor, do you agree that understanding the history of the episode of priapism is important because the history and cause may determine the most effective treatment?
Yes.
Do you agree historical features that should be identified by the physician are, number one, the duration of the erection,
Yes.
number two, the degree of pain,
Yes.
number three, the previous history of priapism and its treatment,
Yes.
and number four, the use of drugs that might have precipitated the episode,
Yes.
number five, a history of pelvic, genital, or perineal trauma,
Yes.
and number six, a history of sickle cell disease or other hematologic abnormality.
Yes.
Do you agree that there should be laboratory and radiological evaluation of a patient with suspected ischemic priapism?
Yes, but I'm not in the position to decide on that.
Okay. Do you agree the laboratory evaluation of patients with priapism should include a complete blood count?
Yes, but I'm not in the position to make that decision.
Okay. You would rely on a urologist to make
I
that
would
decision?
rely on the urologist.
Okay. Do you agree that the laboratory and radiological evaluation should also include special attention to the white blood cell count
Yes.
and to the platelet count?
Yes.
All right. If you were to engage in intracavernous treatment as you just described to the jury, what I'd like you to do is take a pen and draw where you would inject with a needle into the cavernosum.
I don't do this type of treatment.
Doctor, do you agree that any delay in the direct treatment, that being intracavernous treatment of the penis, is not justified?
Check to the
Yes.
form.
Doctor, do you agree that management of ischemic priapism should progress in a stepwise fashion to achieve resolution as promptly as possible?
Yes.
Do you agree initial intervention may utilize therapeutic aspiration with or without irrigation or intracavernous injection of sympathomimetics?
Yes.
All right. Describe for us what therapeutic aspiration with or without irrigation is.
I would not do it.
Now, my understanding is that you treated Mr. Culp with oral pseudoephedrine. Is that correct? When you saw him for treatment of his priapism,
Yes, on 9/17.
and you also prescribed oral terbutaline, correct?
Yes,
And that was also for treatment of his priapism, correct?
yes.
All right. I'm going to read this out for you and see if you agree. There is no evidence for the efficacy of oral pseudoephedrine in the treatment of either prolonged erections or priapism. Do you agree with that?
I had to qualify because it says here ischemic priapism. It was already concluded that the patient has ischemic priapism. So it may not be ischemic. So I would leave it up to the urologist to make that determination. But as far as my resource in the clinic, I have to use it. And then I would like the urologist to give further treatment.
Do you agree that Privatism constitutes a urological emergency which, because of the danger of hypertensive crises, demands treatment in a hospital?
Hypertensive crisis, it can happen in any condition.
My question is, do you agree that it's a urological emergency that demands treatment in a hospital?
Yep.
Yes. At least I have to get the urologist to do the management.
Do you agree the principal disadvantage of using trimix is the increased risk of priapism in susceptible patients?
I had to qualify that.
And how do you qualify that?
Whether the patient had excessive doses or the duration of the problem, then that may determine what approach to take.
Do you agree that if the priapism goes on long enough that a patient may develop permanent impotence?
May develop, yes.
Okay. Some patients will and some patients won't, correct?
Correct.
And we're talking about ischemic priapisms, right?
Well, it's Priapism in general, including non-ischemic.
Okay. And that's the principal danger, isn't it, doctor, of an ischemic priapism, is that if it's not treated and managed appropriately, the patient can become permanently impotent, can he?
Yes.
Doctor, do you agree that prolonged erections resulting from intracavernous injections of vasoactive substances should be stopped after 3 hours and in no case allowed to persist for more than 6 hours?
Are you saying only one injection or multiple injections?
I'm asking you, a patient with a prolonged erection caused by an
For how
intracavernous,
long is the prolonged erection?
that it should last no more than 6 hours.
Right. Correct.
Because going over 6 hours involves the risk of ischemic damage to the tissue, resulting in irreversible erectile impotence.
Yes, I agree.
All right. Or you have to be careful with the patients you select in regards to the use of intracavernous injections like Trimix.
Yes, Of course, that's why we take history and physical.
And that the prescribing physician must be aware he's working with a highly potent drug.
It's dose related,
It
dose dependent. It depends on.
is Trimix a highly potent drug?
It's a potent drug depending on the dosage.
All right, let's stick with that for a minute. Okay. All right, let's stick with the patient flow sheet for a moment. I see a blood test dated 6/1/2010. And
Is that a
then,
question?
I mean, yes, it is. Is there a blood test that was done on 6/1/2010?
Yes,
All right. Whose handwriting is that?
I can't say.
Okay. Go to the bottom where you see shot. See that?
Yes,
Who wrote that?
I can't say.
Okay. Do you know what that shot was for?
Yes,
What was it for?
for the testosterone.
For the testosterone?
Yes,
And one was given on 6/1/2010?
yes,
And then what's the next date next to it?
6/8.
Okay, so Mr. Culp received testosterone shots on the 1st of June and the 8th of June of 2010. Is that right?
That's right.
Okay. What's the next sheet under your patient flow sheet?
It's the progress notes.
Okay. Whose handwriting's on these progress notes?
The name here apparently was done in my front office, so I can't remember.